It's perfectly all right for me, sir.
Hello, Mr. Nitya, am I audible clearly?
Yeah, you are audible, and also your presentation is also there, sir. It's okay.
It's visible, na? Thank you.
Yeah, it's okay.
Okay. Good evening, everybody, and welcome to the session 2 of our pediatric neuromuscular update. I am going to start today's session. Yesterday we covered about congenital muscular dystrophy and congenital myopathy. Today we will continue with the muscle only affected diseases of the children. And for today's session, the chairperson will be Professor Sefali Gulati ma'am, who was my teacher in my MD pediatrics, and she was also the teacher and my guide in my DM pediatric neurology course. So I am thankful for the fact that she spared her valuable time to join our today's session as a chairperson. Now, all the people all the clinicians in our country, whoever a little bit interested in pediatric neurology, already knows Professor Sefali Gulati ma'am. She is the head of our child neurology division in AIIMS New Delhi, and she is the faculty in charge of our Center of Excellence and advanced our childhood neurodevelopmental disorders. And she also established this in few years back in our AIIMS New Delhi Child Neurology Division. And she is the convener of DF program in our AIIMS New Delhi. Also, he is the chairperson of Academy of Pediatric Neurology for the 2021 year, and she is advisory board member of Academy of Pediatric Neurology, and she has over 23 years she has been in IIMS in Delhi, and more than 20 years she has been practicing as a faculty in pediatrics and pediatric neurology. Apart from that, she has received many awards in our prosperous career. Apart from and published more than 300 papers in national and international recognized journals. Some of the awards he has received are Atal Swasthya Bhushan Samman 2019 in 2000, and also the Dr. I.C. Verma Excellence Award in 2018, and Amrit Modi Unique M Prize in 2015. So we are privileged that such an eminent pediatric neurologist and from our country is today here to guide us as our chairperson. Now I will request Professor Sefali Gulati ma'am to take over the session and introduce our today's eminent speakers to the audience. And today we will have two sessions. Professor Sefali Gulati ma'am will introduce them, the speakers. Thank you, everybody. Hi, ma'am. Hi, ma'am.
Session being I in muscles, not dystrophinopathies. You have muscle dystrophies and their spectrum, and then you have the limb muscle dystrophies. And we, as a pediatric neurologist, should understand that anybody coming with something with like DMD is not all DMD. So we have to understand that. Only when we understand, then we can look for it. So, and I'm very happy to introduce the speaker, Lokesh Saini, who is also our alumnus from child neurology at AIIMS, and he is currently assistant professor in PGI, and he has over 100 publications and more than 10 book chapters. And his areas of interest are CP, autism, ADHD, neuromuscle, and neurodevelopmental disorders. And I'm sure that he's going to take it a very good session. Hello, you on the screen. Yeah, I've heard a lot about you, not met. Thanks for having me in. And I now leave the forum for Lokesh to take over for Duchenne muscle dystrophy.
Good evening, ma'am.
Lokesh, can you start? Good evening.
Yes,
good evening,
yes,
Inder. Good evening. Good evening. Can you start sharing your screen, Lokesh? Yeah.
Sure, ma'am.
Basically, sure. Duchenne muscle dystrophy is also, not a single condition. It is also, it is also a spectrum. So I just leave the forum to Lokesh to take over.
Yes, ma'am. Dr. Pratik, is my screen visible?
It is, Beta. It is visible. You can continue.
Okay. Thank you, ma'am. Thank you. I'm very grateful that Dr. Pratik and Dr. Inder has given me this opportunity, and more grateful that my session is being chaired by ma'am herself. She is the mentor who has taught us and bring us where we belong, where we are now. So without wasting time, I want to start the topic given to me. So it is Duchenne muscular dystrophy, which is a, like you can say, it is prototype of neuromuscular disorder, most common condition which you see in your general clinics as well as pediatric neurology clinics. We are fortunate to train from AIMS New Delhi, where we have a separate pediatric neuromuscular clinic where we see lot of cases of Duchenne muscular dystrophy and other myopathies, CMDs, myasthenia. So there is spectrum, but most commonly we see this condition. So to start with, so some things which we all know, and some things are meant for MD student in my talk, and some things are meant for beyond who are doing post MD, DM or fellowships. So it is the most common muscular dystrophy. 1 in 5,000 live male births. Some books or some literature say it is 3,500 live male births. But recently it has come that it is prevalence is 1 in 5,000 live male births. It is an X-linked condition, and it occurs due to mutation in dystrophin gene, and it is progressive neuromuscular condition. So you can also say it is a it is causing progressive neuromuscular impairment. As we all know, it is a neuromuscular condition. So one should remember it is causing progressive neuromuscular impairment. And very important, so we think usually that it is a muscle disorder, but one should remember it has multi-system involvement, and one of the significant involvement is of cardiac muscles. So just a this is a diagram, or you figure just want to like explain it to you, like what is where it is like where it is lying, this dystrophin gene. So this dystrophin gene is it's a big, this is blue colored, which I have just marked. So this has two ends. One is intracellular end, which is bound to actin domain, and one is bound to dystroglycan end. So most of the mutation occur at the dystroglycan end. And what does dystrophin do? So what does dystrophin do? Dystrophin act as an anchor between dystroglycan and the inner matrix, and it gives stability to the membrane, which is bound to the dystroglycan directly. So you can see dystroglycan is bound to this membrane, and whenever muscle contract, this needs a support, and this support is given by this dystrophin protein. So if dystrophin is short or dystrophin is not there, and if it is not functional, what will happen? Whenever a muscle contract, there is a breakdown in the cell membrane. And what will happen after this breakdown? The calcium which is there, it will move in, and CPK, which are energy store of muscles, it will go out from the brakes. And that is why you get rise in CPK in this muscular dystrophies. As the muscle membrane breaks down, the CPK goes out, and calcium, which is outside the membrane, it comes in and causes secondary toxicity. So this is a image where just I want to highlight that normally in immunohistochemistry, you see dystrophin as this like well-defined membrane you can see all around the muscles. And in DMD, this membrane structure is completely gone. So if it is Duchenne muscular dystrophy, it is completely gone. And if it is Becker form, which is like partial expression of dystrophin, then you can see in immunohistochemistry you see the ill-defined membrane structure. And in hematoxylin and eosin staining, you can what you can see is lymphocytic infiltration and fatty tissue infiltration in between the muscles and loss of the membrane structure. So other than muscles where all you can find dystrophin, so retina is one place, brain is one place, smooth muscles is one place, and very important is cardiac muscle. So other than muscles, you find dystrophin in all these primary places. So what is the meaning of this and what is the implications of this? We will be seeing in the next few slides. So coming to the basis genetics, gene locus is X arm of 21. X chromosome, and it is located on the P shorter arm, and one of the largest gene, and it has 79 exons. And what are the molecular defects? So most commonly are deletions, duplications, and point mutations. Most common, one should remember for MD or post-MD who are preparing. So deletions are the most common defect which you see in Duchenne muscular dystrophy. And after deletion, duplications. That is why first investigation you do, which is ethical, it is ethical also and advised also, it is MLPA, which detects all these large deletions and duplications. So MLPA suffice most of the times. If you don't get your diagnosis in MLPA, you can go for gene sequencing later. And one should remember there is no relation between the size of deletion and the severity of the disease. So coming to clinical presentation. So children start manifesting clinically at around 2 to 5 years of age typically. They come with complaints of frequent falls, difficulty in climbing stairs and running. And if they run fast, they tend to fall. And some of the children starts walking on toes. So toe walking is another clinical presentation. So we are talking about typical clinical features. So some boys rarely they can exhibit all these symptoms in less than 2 years of age. So you can see children as early as 1 year coming with these complaints, like their parents may be extra vigilant and they can notice all these things that he is has difficulty in getting up from floor and all these things. But usually they come after 2 years. And frequent non-motor manifestations are known. And what are these? Intellectual disability, autistic features can be there, ADHD, sleep and articulation difficulties, and very important is short stature. So if you see your cohort of DMD in your clinics, most of them have short stature and poor weight gain before starting steroids. So after starting steroids, they may gain weight, and they give a pseudo feeling of healthiness, but it is most of the part, like most of their muscle mass is pseudo hypertrophy, and that is because of steroids only. So usually they are nutritionally deprived and they have failure to thrive. So coming to uncommon presentation, the uncommon presentations are isolated cardiomyopathy. So some of the children with especially Becker muscular dystrophy, where partial dystrophin is present. So they can present with isolated cardiomyopathy features. They can be enrolled in gastro clinic. They can go for extensive workup by a gastroenterologist for asymptomatic elevations of enzymes. So AST, ALT is raised. They will be referred to the gastroenterologist, and eventually after every investigation has been done, they realize it is not related to liver primarily. So another presentation is muscle cramps with myoglobinuria. So around 7-8 year old boy parents come that he has participated in a race in school, and after participating, next day he has started having this red color urine or the myoglobinuria. So they come with this complaint, and that is the first time you see this child. And some of these children may have like most of these children may have this calf hypertrophy, but some of them don't have this calf hypertrophy and they present with myoglobinuria occasionally. So one should remember all this atypical presentation, and some very important is symptomatic girls. So or unexplained transaminitis and hyperactivity. So whenever you have this combination, isolated in isolation also and in combination also, always examine muscle. And girls, like this is a girl presented to us, the short stature was there, presenting complaint, and at 10 years she has presented to us, and before that she has been evaluated at multiple places, and because only at 9 years she lost ambulation, and that is why they've come to neurologist. Somebody has referred to them, and she has turned out to be Turner syndrome with Duchenne muscular dystrophy. So all these atypical presentations can be there. Coming to clinical signs, so till now we have seen symptoms, and now we are coming to signs. So what we are going to see, these are the complaints which we have already seen, and what we are going to see is selective muscle group weakness. So some muscles are preserved relatively and some muscles are involved early. So you will get selective muscle group weakness. Classical example is early neck flexor weakness, whereas extensor group is preserved till late, neck extensors. Selective hypertrophy, so some muscles are hypertrophied, and even in one muscle, part of the muscle is hypertrophied and the remaining part is atrophied. So classical example for this is deltoid and infraspinatus. So in infraspinatus and deltoid. So deltoid central part is hypertrophied, anterior and posterior is atrophied. And in infraspinatus, inframedial belly is hypertrophied and superolateral border is atrophied. So in same muscle, you can find hypertrophy and atrophy. So this is a specific feature of Duchenne muscular dystrophy. And another sign which we have to look for, early contractures. So what are the patterns of weakness which you see? One classical pattern. So proximal are involved before distal, lower limb before upper limbs, pelvic girdle weakness. You can observe in all Gower sign, waddling, and lordosis is there due to pelvic girdle weakness. Neck flexor weakness, biceps and triceps are weaker than deltoid muscles. As I have already told, deltoid is the another hypertrophied muscle other than calf muscles. Cranial muscles are spared relatively, or you can say they can be involved rarely or late. We can see in adolescents or adults with DMD with cranial muscles involvement, like you can just observe mild facial weakness in their late stages. So coming to this signs pictorially, so this is a classical thing which you don't miss, usually calf hypertrophy, but always look in the clinical context whenever you are interpreting this calf hypertrophy. So as you all know, in athletes and children who run and active, they can have calf hypertrophy. Even a child with spastic diplegic cerebral palsy, because he walks on toes most of the time. Children with autism, they walk on toes most of the time. They can develop secondary calf hypertrophy, but that in those cases that is true calf hypertrophy, not pseudo calf hypertrophy. Coming to this, another sign which you can get help whenever there is calf hypertrophy is missing, but you are suspecting Duchenne muscular dystrophy. Sensitivity of this sign, valley sign. What is valley sign? I am going to tell you. Sensitivity of this sign to pick DMD is 90%. Okay, so what is this? So as I already told, other muscles which are hypertrophied. So there are many muscles which are hypertrophied other than calf muscles in Duchenne muscular dystrophy. One is infraspinatus, deltoid, tongue, and many more. So one should remember most common is calf, which is getting hypertrophied. Second most common is infraspinatus. Third most common is deltoid muscle. So this is the order. So you can easily see infraspinatus, infromedial belly is hypertrophied here, deltoid hypertrophied here, and the muscles which are making posterior axillary fold is atrophied, or you can see appreciate it here. Since like this sign came in existence in 1992 by a paper from Dr. Pradhan, and the image he has shown in that paper where you can appreciate this valley very beautifully is this. So you can see deltoid here, you can see infraspinatus, and this is the valley, which is nothing but like depression because of weakness of posterior axillary fold. So coming to this, like we can see these videos also. So neck flexor weakness. So child, like this child, 8-year-old, when asked to flex his neck, raise his neck from the supine position, is not able to do it. And the same child can do it like there is no extensor weakness, so in prone position he can do it very easily. So this is also a useful sign in young child whenever you are in doubt, whenever CPK report is dubious, or so these are one of the signs which can make you make you think more in direction of Duchenne muscular dystrophy. This is very classical sign. Just for MD students, I am showing this classical Gower sign. So one should remember they usually take their legs behind whenever they are getting up. If they are not taking their legs behind and only, so again if you see, he'll take his legs behind and then only get up. So in Duchenne muscular dystrophy, you will see this thing, and in other Gower sign, due to like other LGMDs or spinal muscular atrophies, they can get up. They will also require support, but they can get up without taking their legs back. So this is one of the useful clinical observation when you are seeing children from like doing this Gower sign. We can make out, okay, this is most likely Duchenne muscular dystrophy, and this is not DMD or maybe some other LGMD kind of muscular dystrophy. So coming to clinical signs, muscle enlargement, I've already told calf hypertrophy, pseudo hypertrophy is there. Tongue, brachioradialis, deltoids, infraspinatus. So first is like most common is calf, second is infraspinatus, and third is deltoid in this order. And these are other muscles, tongue, quadriceps, gluteus. Contractures are there, so we have to look for contractures also. Most common you can see in TA, and you can see in iliotibial bands, wrist extensor elbow also can develop later stages, and in shoulder also, and when they grow up. So coming to the diagnosis or flow chart. So this is whatever we have learned and whatever we have understood. So when to suspect DMD? So whenever unexplained increase in transaminases, there can be 3 scenarios. They can be referred for this isolatedly. So unexplained increase in transaminases, if family history of DMD is there, if no family history of DMD but child is not walking, Gower sign or toe walking, any age, especially less than 5-year-old. So there are 3 relatively common clinical scenarios when with that they come. So you do serum creatine kinase total, it is increased, testing for, so as I already told, most commons are deletion and duplication. So you usually can do MLPA here. MLPA, if no mutation found, you can go for genetic sequencing. So this is the usually common flow chart. If you don't get your diagnosis even after genetic sequencing, sometimes you require help of muscle biopsy in today's era, because previously before this genetic era, we used to take help of muscle biopsy. We can also do it now, but it is after, if it is like if genetics is not amenable, or we cannot do genetics, or it is negative, and we are strongly suspecting Duchenne muscular dystrophy. So usually by 2 years, they have minimal or no symptoms. By 8 years, this all classical features, lumbar lordosis, you can see calf hypertrophy, okay, and waddling and all these things develop. They have difficulty in walking, frequent falls can be there. And by most of the after 12 years or by 12, 13 years, they are not, like they stop ambulating. They need support for ambulation, or they might catch a wheelchair or bed. So summarizing these clinical stages, so by till 2 years they are pre-symptomatic phase, early ambulatory phase by 2 to 6 years, and then they are in late ambulatory phase in 6 to 11 years, and then after that they lose ambulation in stage 4 and stage 5, and after stage 5 they are prone for all the multi-system complications. So again, if summarizing minor symptoms in first 5 years, first problems in walking and climbing stairs, and as that age age advances, they develop impaired arm function by 15 to 20 years of age, and nighttime ventilation requirement is there by 15 years of age. It starts with 15 years of age, and eventually they need it for lifetime. 24-hour ventilation is also required in once they cross around 25 years of age, and at this age 20 to 25 years, 25 to 30 years, there is high mortality, and most of the cause of the mortality is cardiovascular complications. So coming to complications, as I already said, what are the complications? So respiratory, cardiac, psychosocial, endocrine, GI, and orthopedic. So almost every system is involved. So in cardiac, cardiomyopathy and arrhythmia can be there, restrictive lung disease and respiratory infections in respiratory complications. And this occurs because of poor, because they not able to cough properly. So there is secretions, they have a lot of secretions, stasis of secretions, and also they are prone for aspiration pneumonia due to smooth muscle dysfunction. And orthopedic complications like osteoporosis, fractures, contractures, and GI complications, reflux dysphagia, constipation, undernutrition or obesity. Most of these GI complications are due to smooth muscle dysfunction. Endocrine complications like impaired growth, delayed puberty, adrenal insufficiency, and psychosocial complications like anxiety and depression, as they are cognitively normal most of the time. So they understand what is going on, and they eventually go in depression. So management is multifactorial, and neurologist and therapist form the major core of this management. So the child requires extensive therapy. Orthopedicians will be needed definitely, and all the kinds of therapies are required. So neuromuscular, what we can do, you can do functional assessment at baseline and after starting any form of therapy. So many functional assessment tools are available: 10-minute walk time, 6-minute walk test, time to stand, Bigness score, which is available for upper limb as well as lower limbs. Physical therapy is advised, and it is the mandatory thing which you should always tell children with Duchenne muscular dystrophy. So preventive home stretching is advised 4 to 6 days per week. Orthotics are advised, preventive nighttime AFO in ambulatory boys. So remember, when they are ambulatory, they have to wear AFOs nighttime. When they are non-ambulatory, daytime AFO is required. And KFOs also required sometimes based on case situation, like it is case to case basis. Exercises, very important: regular submaximal aerobic exercises, including cycling and swimming. So remember, they are advised aerobic exercises. And what should not be advised? So any form of high resistance exercise and exertion. And also remember, never advise weight bearing exercises. They are contraindicated in Duchenne muscular dystrophy. That will lead to more muscle injury. So coming to the mainstay of treatment, which is the part of any clinical regimen, whenever you see a child with Duchenne muscular dystrophy, steroids. And if you have been asked what are the role of steroids, what you should give, why you should give steroid, so remember these 3 points. So they prolong ambulation, they preserve respiratory function, and they retards scoliosis development. So these 3 are primary functions of steroids which you give. So you start with a dose of 0.75 mg per kg per day for ambulatory children, or you can also use other forms of steroid like deflazacort, and this 0.9 mg per kg per day. This is so you can use this deflazacort, you can use prednisolone, and once they are non-ambulatory, you can use the reduced doses like 0.35 to 0.45 mg per kg per day, and based on the side effects and function deterioration, you can titrate your dose. But always remember, steroids are the mainstay of treatment, and they what does they do? They prolong ambulation, they preserve respiratory function, and retards scoliosis development. So coming to recommendations for assessments and intervention. So cardiac, you should do yearly ECG, yearly echo. AC inhibitor are indicated if symptomatic or abnormal echo is there. So if ejection fractions starts decreasing, or if they are symptomatic cardiac wise, you need to start AC inhibitor. Respiratory functions, yearly FVCs, and vaccination is very important. Before starting steroid treatment, one should vaccinate these children with pneumococcal, varicella, and influenza vaccines, and always ask for history of obstructive sleep apnea. And this can start as early as 5-6 years of age, so they can have this problem of obstructive sleep apnea. And if it is there, they might require nocturnal assisted ventilation for sleep disorder breathing. Bone health is extremely important. Yearly vitamin D and DEXA is recommended. X-ray spine is indicated if they are complaining of pain in spine. Vitamin D with calcium, if less than 30, vitamin D, if it is less than 30, it should be given. And bisphosphonates are required if vertebral fracture is there. Endocrine assessments, so height 6 monthly until final height achievement, and SMR also 6 monthly from 9 years of age. And they might require, so you need endocrine consultation if this is faltering. They might require growth hormone therapy or testosterone. So you have to assess all these things and take endocrine evaluation if SMR and height has some issues. Gastrointestinal, so all these features are due to smooth muscle dysfunction. So if this is present excessively, patient might require gastrostomy tube placement for nutritional rehabilitation. And orthopedic assessments, you need to do spine visual inspection annually, as well as X-rays are required if it is showing curve. So if it is tilted, it is showing scoliosis, and if it is this curve is more than 20 degree, surgery is indicated. You need to consult an orthopedician. So home safety measures, very important. Remove obstacles at home like unnecessary furniture, toys, rugs. Safety on slippery surfaces, remove slippery surfaces. Home modification, what you can do is non-slip mats you can use in bathrooms. Grab bars in toilets can be used. Bath seats should be advised. Handrails or stairways should be provided to them. So coming to cognitive and behavioral issues, so as I already told that this is also very common in children with Duchenne muscular dystrophy. So intellectual disability, autistic features, or autism per se, ADHD, and learning disabilities. So they form a complete, this cognitive and behavioral conundrum. These children, they sometimes goes to psychiatry department with these complaints, and then referred back to pediatrics. So very common intellectual disability is up to the tune of 30 to 40%. And remember, verbal IQ is more affected than performance IQ. Problems with verbal learning in school. And this is very important point one should remember or make a count, that no correlation exists between degree of muscle weakness and cognitive dysfunction. Okay. And there are certain exons which code for this certain dystrophins which makes them prone for this cognitive dysfunction. What are these? So exon 63 mutation, exon 31, and exon 1. If these are affected, and these exons code for dystrophin 427, dystrophin 260, dystrophin 71, and dystrophin 140. So certain dystrophins, if they are like certain their exons are mutated, so these children are prone for cognitive dysfunction. So significant associations are there with autism, ADHD, and less commonly they can also have OCD like symptoms. And for all these, neurobiological basis is unclear, and this adds on their difficulties in schooling. Already they have difficulty going to school uh, because of their motor problems, and additionally because of this they suffer enormously. And why this slide, what is the main basis, like purpose of this slide is here, like why I want to highlight this cognitive dysfunction? Because these children, when they complain to you and when you diagnose ASD, ADHD like symptoms, OCD, remember these interactions with, whenever you prescribe some drug like atentrol or atomoxetine or risperidone, so what will they cause? They will cause weight gain, they can be cardiotoxic, so already they have issues. So always remember this association. So before prescribing drugs for all these neurodevelopmental or neurobehavioral issues, remember these two side effects and act accordingly. So as I told, that they are prone for self-depreciation, insecurity, marginalization, isolation. They go in and later stages of their life, they go in depression, and they are very prone for anxiety and depression. So coming to, like, this is the general or we have covered symptoms, signs, clinical features, basis of how does it occur, and how do you take routine care of these children. And this is this is the topic, or you can say next five slides, which as I'm devoting on recent therapeutic advances. So DMD therapy can be disease specific and complications you can handle. So in disease specific therapies, primary, or you can say genetic therapies, which cures the disease, which tries to cure the disease, are there, and secondary, which decreases the inflammation and encourage regeneration of the muscles. And complications, like other therapies which deals with the complications, cardiac complications, respiratory complications, and bone health. Coming to the disease specific or genetic therapies, so gene replacement and other genetic therapies. One is exon skipping. So exon 51 is eteplirsen. Exon 53, exon skipping is there. Newer drugs are Viltepso is one drug. Okay, and another gene replacement, in gene replacement therapies are, one important thing is stop codon read through ataluren, for which trials are going on all over world. Even AIMS New Delhi is one of the site for that, and I think that the recruitment has just been stopped. And another thing is gene transfer. So in secondary processes, reduction of inflammation and fibrosis. So what we are doing by giving steroids, we are reducing the inflammation and fibrosis. So these are the certain, like, drugs, prednisolone versus deflazacort. You can choose based on patient to patient basis. Then NF kappa B inhibitors can be tried, and anti-fibrotic agents can be tried. But what is recommended is glucocorticoids and their analogs. So muscle growth and regeneration, cell-based therapy, all these are experimental therapies. Cell-based therapies, upregulation of cytoskeleton protein, and myostatin inhibition. So all these are experimental therapies. Nothing has been approved till now, but what has been approved is glucocorticoids. So targeting complications. So these are very important for cardiomyopathy. If you identify cardiomyopathy, you start AC inhibitor, you start this beta blockers, nebivolol, remipil versus carvedilol. You can start any of these. spironolactone versus eplerenone. So this is aldosterone antagonist. Respiratory complications, if you are saying you use it, there is a role of idibenone, but all these are have been tried, but nothing is very beneficial. But still, if you find this complication, there is no harm trying all these drugs. And if bone health is the issue, you supplement calcium, vitamin D, and if there are fractures, you give bisphosphonates. So coming to this list of newer drugs which are coming day by day, as the from recently, like from 2017-18, you can see a lot of drugs are coming, lot of therapies are coming, and some of these are FDA approved. So eteplirsen is the one drug which is acts by exon skipping. I will be telling in my next slide what is exon skipping. And another two drugs, golodirsen and vitolarsen, which is exon 53 skip. They act by exon 53. They are also based on principle of exon skipping, and exon 53 they are exon 53 skippers. So, and deflazacort is approved by FDA in 2017, which is nothing but a form of steroid and a steroid analog. And ataluren, which like recently the trials has been concluded, and what does it do? It is stop codon read through. So it is FDA. It's not FDA approved till now, but European European Medical Academy has approved this drug. But look at the cost of these drugs. So they are really unrealistic as of now, but we believe that these prices will have some regulation in near future. So just look at this exorbitant cost for a year's therapy. So what is exon skipping? So just understand this is DNA and there's mutation has occurred here. So these are different exons. Now for this, like if this has to be translated into pre-mRNA, then mRNA and protein. This needs a structure like this here, which is not there because mutation has happened here. And now there is like there's a protein with like there is a exon which is having this type of shape. This is an example. So one can understand it cannot be clubbed with this. So what will it cause if they are combined? It will cause frame disruption. So what does it need? If we remove this from this frame and this comes here, so they can be combined easily. So what we have to do, either we can remove this thing, or we skip the exon from we can use exon skipping. So this just directly jump whenever this reading frame is we are like the protein reading frame is happening. So and the usual scenario when you are not doing anything, what will happen? Because it will act as a stop termination codon here itself, because it will not progress. So pre-mRNA will be spliced and mRNA will form with a reading frame disruption, and the protein whichever will be formed is non-functional. So if you target exon skip, so if you skip this exon by using some therapy like exon 51 eteplirsen, if you use in exon 53, there are two names which I have given. So if you use this exon is skipped and this comes here and attaches and reading frame restored, and what you get is partially, you will not get the normally functioning protein, but partially functioning protein you will get. So you will get at least some dystrophin. So ataluren is sorry. So
viewers request not to again annotate there.
Hello.
Yeah, please continue, sir. Continue, sir.
Okay. So ataluren, as I already told,
Lokesh,
yes, ma'am. It is Yes, ma'am.
Lokesh, will you be wide? We've already lost 12 minutes, So
Okay, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
the wind fast.
So it is
Because it's 42 ho gaya na,
so-
because we yeah.
okay, ma'am. Last slide, ma'am. So it is oral agent ongoing trial just concluded in India, and it is mechanism of action is stop codon read through. So I will okay, so I will skip this slide. So, and most recent advances is genome editing. What is genome editing? We use genetic scissors. These are CRISPR technology. This is CRISPR technology. So as I already told, this like this slide which you have seen. So if we cut this from here and just stick this to here, so we will get our partially functional protein. So this is what the CRISPR technology do. They edit this. So they will remove this part and remove it from here, and just so that reading frame is restored. So this is latest advance in genome, this DMD therapy, and most probably this might get some success in gene therapy, which we are targeting from many years. So this is like with this slide, I want to end my presentation. I'm ready for any queries if there are. Thank you.
Thank you, Lokesh. I think because for want of time, we'll just finish the other topic and have the discussion at the end, if that's okay, Pratik.
Sure, ma'am.
Questions at the end. Pratik, is that okay if we take the questions at the end?
Yes, ma'am.
Because
It's
we're
okay,
running
ma'am.
back. Yeah. We'll
Yes, ma'am.
take the questions at the end. You can please put them in the chat. We will take all the questions for sure. But let's just have the second talk. And the second speaker for today is Dr. Sumit Dhawan, who is MD Pediatrics and DM Pediatric Neurology from PGI Chandigarh, and is consultant child neurology and epilepsy at Maharishi Markandeshwar University, Mulana and Apollo Clinic, Chandigarh. He has over 50 publications and 5 book chapters, and neuromuscular disorders is his area of interest. Dr. Sumit Dhawan will be talking about limb girdle muscle dystrophies, and it is very important for us to understand how to suspect them. Dr. Sumit, can you share your slides, please?
Dr. Sumit sir.
Dr. Sumit, please you can share your slides. Till he is okay, stop sharing. It's okay, then we can talk in the end. Yeah.
Any issue, Sumit sir? You can make it full screen there. Any issue, sir? You are not audible, sir.
Can you unmute yourself? Dr. Sumit, can you unmute yourself?
I think sir is having some issue with the audio. Just I am trying to solve it. Sir, unmute yourself there. You have to
I
unmute
think
yourself.
can you please can you Can you talk to him on the phone? Meanwhile, we can take the questions while he comes on board, right?
Right, madam, right.
Talk to him on the phone. That would then will save time for others. We can just do. We can just take the questions in the chat. One sec. So Lokesh, there's some questions for you in the chat.
Yes, ma'am.
So it says. It says, can you please tell when to suspect DMD in females? And are there any specific tests for females? And sir, can you please explain the difference between probable and obligate DMD carrier? This you can tell, then the others are not related. You can tell
Okay.
this.
So
Want to take this?
as I told in my slide that okay, females can also have Duchenne muscular dystrophy. They can present with Duchenne muscular dystrophy features with classical features, and sometimes they present with cardiomyopathy isolatedly. So in that scenario, it becomes very difficult to suspect that they can have Duchenne muscular dystrophy, but family history helps there. So most of the time, someone of their male members in their family already died in so brother. So you can get that history in females, and uh, sometimes they present with classical features with calf hypertrophy, short stature. When one after ruling out the common condition of like thyroid in females, you should suspect Turner syndrome, where only one X chromosome is there, and they will manifest typically. So these are the certain conditions. So are there any specific tests? No, you can get your diagnosis by routine MLPA, as well as if not an MLPA, then gene sequencing. You can get the diagnosis. So there is no specific test. And another question is, sir, can you please?
Hello.
Okay. So okay. So is there any score for disease severity or progression? Sumit?
Hello, Dr. Sumit sir.
Sumit, please
Sir,
mute.
Sumit sir is joining, sir. He is online. He is joining, sir.
okay. Till that time, we can take the other questions.
Yeah.
I think I will request Safali ma'am to take the other questions.
Sir, is there any score for disease severity or progression? So we will do baseline assessments using 6-minute walk test, Vigdus score, and you can do all these tests. And these test time taken will be increasing as the severity increases. Even the Gover's sign, time to get up from the floor, the time taken to get up from the floor increases as the severity of the disease increases. So there are scores which you can do at baseline, and you can compare them as the disease progresses with the previous one.
You are on, sir. You can now speak on. Yeah.
Thank you, Lokesh sir. I think we can progress with Dr. Sumit sir's presentation for now. I will request Dr. Safali ma'am to permit Dr. Sumit to present the second half of the presentation for today.
Yeah. I'm audible?
Yeah, you're audible, but
yeah. So good evening, all. Sorry for the delay. And
can you please?
Yeah.
Please take on. Please start. Dr. Sumit, please start. We'll take the rest of the questions at the end.
Yeah, ma'am. Thank you, ma'am. Thank you to host the presentation. So I'll be discussing about limb-girdle dystrophy and other dystrophies. So the topic is a large and a difficult one. Often the cases are few, so the approach is difficult to remember because we do not get much of hands-on. So I'll be discussing the approach to muscle disease and dystrophies. So basically will be discussing a pattern recognition approach for children with chronic progressive weaknesses, which has
Sumit sir, you are not audible.
On the contrary, in the muscle dystrophy, there is disturbance in the structural protein which leads to muscle fiber necrosis. So the fibers get lost as the age progresses, and so the weakness progresses. So this is the cardinal differences between a myopathy and a muscle dystrophy. So as we said, so progressive muscle dystrophy is a primarily inherited and degenerative disorder of the muscle, which is characterized by weakness and wasting, which is often progressive. And the most cardinal protein which is affected is dystrophin, and the prototype is DMD. So as we have seen in the previous presentations, there can be various signs of the muscle diseases, and a progressive muscle disease is DMD. However, there are very subtle differences which lead to differentiation between dystrophies and the other kinds of muscle dystrophies. So we'll be discussing this in the further presentation. So the pathology is similar in most of the dystrophies as well as muscle dystrophies. There is muscle fiber loss, there is increasing amount of connective tissue fat depositions, and later which leads to longitudinal splitting and necrosis of the muscle fibers. Often the muscles of the heart and respiration are also involved, leading to cardiomyopathy and respiratory muscle weakness. So, whenever we see such a patient, what are the key questions? We follow the typical neurological approach. What is the onset, duration, and progress and evolution? So, based on these three key features, we can narrow down any muscle dystrophy or probably any kind of muscle disease. So, age of onset can depends on whether it's a child onset, adolescent onset, or adult onset. The duration, the progression of disease, which is defined as the onset to peak. So when was the child first normal? And the rate of muscle weakness, which is the very key symptom which is leads to the diagnosis. The next most important thing is what is the localization of the problem. So similar progressive weaknesses mimicking spinal cord disorders, myopathic disorders, neuropathy, and NM junction disorders. So my approach will be that you should first be able to differentiate which is the key structure involved, and then what is the further etiological and pathological subtype. So any child with chronic progressive weakness can have a differential diagnosis, neuromuscular disorder including a myasthenia, peripheral nerve disorder including different kinds of hereditary neuropathies, myopathies, and spinal cord disorders can rarely also have similar presentation. So coming to the stepwise approach. So what are the positive and negative symptoms? Now the positive symptoms for any muscle disorders are similar. However, the dystrophic disorders mainly have weakness, contractures, and hypertrophy. Sometimes there can be a component of exercise intolerance or muscle atrophy. Other features like myalgias, myoglobinuria, and stiffness are rare in muscle dystrophies. Symptoms like myalgias, muscle dystrophies rarely have myalgias or muscle stiffness. So if these two symptoms are present, then we are often dealing
Sumit
with.
sir, your slides are not changing, sir. Excuse
Okay.
me, sir, to interrupt. Slides are not changing. You just check it, sir.
Okay.
Click on the next slides. It will come on and make it full screen, sir.
Yeah, it's visible right now.
I thought that
Yeah.
was problem with my net connection.
Just
Yeah,
make it full
make
screen,
it full
sir.
screen, please.
I'm on full screen.
I can just see your first slide. Yeah, now it's okay. Myalgias वाला slide दिख रहा है अभी.
Yeah.
See the myalgia slide. Earlier only your first slide was there.
Okay.
Make it full screen actually. This is not full screen.
kindly present on a PowerPoint presentation so that the screen would be full?
Yeah, it's visible right now.
Can you press on the button for PowerPoint presentation? That will make the screen full. That small logo downside near the volume. That yeah.
Is it full screen right now?
Sir, just click on the bottom.
You just have to click the slideshow button at the bottom right corner.
No, I'm already on the screen button.
Sir, it's nearby the bottom right corner. There is a just before the where 60% is written. Just before that button, sir. You can just click on that button, sir. Yes, sir. Just click on that button.
Can I make a suggestion? Can you mail the slides to Pratik? Then he can load them if there's a problem with the connection from your side.
Okay,
Yes,
just
sir, that would be
Send the slides to Pratik right now, so that then he can just put it from there. So that will be simpler and won't waste time. There may be connectivity issues from your end.
okay.
Yes, sir. My mail ID is I am just sharing, sir.
If you have it, or should I just summarize something of DMT and I have the questions with Lokesh, or do you have the slides? Pratik, can you please tell me whether I
Sumit,
can
sir,
summarize something of
I have
DMT
put my
and
mail ID in the. I think if he mails, I will just make it presentation from here. I have shared my mail
okay.
ID in the chat
Meanwhile,
box.
okay.
Sumit,
What
sir?
I'm doing is right now, just once. Okay, so no, Pratik, you please talk to him on the phone. Meanwhile, we just do some summary. Just okay. Let me just. So Pratik, can you talk to him on the phone? Meanwhile, we just have a summarizing and do the queries. I just wanted to
Definitely,
make some comments, but yeah, I just wanted to make some comments. I want some take-home messages there for the for the residents and the clinicians. We should understand that dystrophinopathies is a spectrum which has very clearly been mentioned by Lokesh, and we have to think about DMDs, intermediate outliers in BMD, and obviously what he mentioned about the DMD-associated dilated cardiomyopathy, muscle cramps with glomerular, asymptomatic elevations, and manifest carriers. That was very important to understand. And this is important. And one thing we have to remember that there's something called an in-frame mutation and an out-of-frame mutation. In the severe and typical Duchenne's, you have an out-of-frame DNA mutation, and so the end product of the protein is not made. And but there is in the milder disease, and in that is a Becker's, you have an in-frame mutation. This is one thing which you should remember. And very nicely, Lokesh has mentioned the different isoforms which are there. And we also talked about the Gowers sign. But I just wanted to mention that the Gowers sign is actually getting up upright from a supine position, and modified Gower is from the squatting position. And what as we have to remember for sarcoglycanopathies, you have the Gower sign in which you have the adductor muscle weakness, and Gowers in DMD is more of an abductor weakness. That is something to remember. And what about there is a differential hypertrophy of muscle in DMD. So basically, what happens is most of them it is a pseudo hypertrophy with the deposit
Madam, excuse me, just unmute yourself there. Madam, there is some system error. Just unmute yourself for a second.
No, I'm trying to.
Yeah.
So I keep unmuting myself and then I get muted. So how much was audible? Nothing was audible?
Yeah, now it's okay. Just for a
Nothing was
second.
audible?
Yeah, for a second it was not there. Rest of the
No,
things
how
are okay.
much could okay, then it's okay. Okay, fine. So basically, we have talked about the Gower sign and the modified Gower sign that is there. Something which you should also remember that why do you talk about hypertrophy? So my hypertrophy which is there is attributed to the deposition of fat and connective tissue, giving rise to the pseudo hypertrophic muscle dystrophy term. But there is also true hypertrophy with muscle enlargement early in the disease course. Reasons for hypertrophy in certain groups and atrophy in certain groups is yet unknown. But they say, there is differential expression of various proteins in different muscles, which has been proposed. So this is why, because you should understand why we're talking about valley sign, why is there? So there, obviously, a bright clinician will have to think. There is a differential expression of various protein in different muscles proposed. And this is also, why certain muscles are having hypertrophy. This is because it has been proposed that muscles which are used heavily in utero and early in life, such as the tongue, diaphragm, and the limb flexors, they get involved early, and which leads to necrosis and may even regenerate and then hypertrophy. So that we should understand this. And regarding the various signs, kapha hypertrophy is present in 93%, TA contracture 70%, winging of spacula in 1/3, and kyphoscoliosis in around 13-14%. This you have to remember, it becomes important. Pulmonary function test may be abnormal, even in 5 to 7 years. One thing which got missed was sleep disordered breathing has to be seen. They have a lot of obstructive sleep apnea up to 63%. And you have, as very rightly Lokesh had mentioned, that you have, the dystrophin expression in various muscles. So we have to look for, smooth muscle dysfunction in the form of vascular, gastrointestinal, and, we have to see for the urinary bladder, voiding and all that. These problems can be there. ID and neurobehavioral he has mentioned, which gets missed many times, which is very important to understand. And we don't have to monitor CK for this patient and follow up. This we should remember, because many patients are following the CK levels. This should not be done. Other thing is, now we had started when studies either the skin biopsy can replace the more invasive muscle biopsy. In the skin, you have this sweat glands, and then you have the erector pylori muscle. So if you stain this muscle on skin biopsy, that also, so we have had many studies which have shown that it can possibly replace. So this is something upcoming. And now some ultrasound muscle is also being there and being investigated for being used in these cases, in addition to MRI. So one has to keep that in mind. And regarding the management, we have to remember that the mainstay is the multidisciplinary management. And one question was there, how do you monitor? So as Lokesh has very rightly pointed out, you have the time functional evaluations, and then you have this which are doing by the the 6-minute walk test and all, and walking this 9 meters, 10 meters. Then you have the climbing the stairs. So all these these are time functional scales. Then you have the MMT total score, then the Vignos and the Brooks scores, which and Gower's time. So you keep following them up, and the functional evaluation of Dushin is what is you're doing on follow-up. So that we have to understand and see. Steroids remaining the mainstay, yes. And all what he has very nicely mentioned everything about the supportive care in these children. We are giving steroids initially with, I wanted to clarify that we give steroids initially 0.75 milligram per kg, but when the child becomes non-ambulatory, that time we reduce the steroid dose to about half. So then that is there, but then still you continue the steroids. About 15 years back, we used to stop the steroids when the child was becoming non-ambulatory, but now we reduce the dosage. So that one thing which is very important to remember, because we understand that it is being affected in various other, it's not only the skeletal muscles, various other muscles are there. And it's still debatable regarding whether we can use Becker's, we need to use prednisolone therapy. Some postulated importance is there. Manifesting carriers, we have been asking about it, so that is there. Manifested carriers can present with either mild or occasional severe things, despite the recruitment of some satellite cells, which are there, dystrophin positive satellite cells. They may have problems which are there. And as you mentioned rightly, Dr. Lokesh has mentioned about the cardiomyopathy being present. There'll be a positive family history. There may be heterozygosity for dystrophin mutation, or there may be cytogenic abnormalities like X autosome translocations with breakpoints in X21. So carrier status has to be proven by linkage analysis. There may be persistent elevation of CK in there, and a positive family history is always required, when you are seeing these patients. So it can be manifested like he mentioned about the Turners, or you may have skewed inactivation, or you have exome or translocation, or you have uniparental disomy and homozygosity. So there are various ways in which you can manifest, and they have a lot of spectrum. The phenotypic spectrum is there, and you have to do the molecular studies for diagnosing these patients. And we have to understand that this will lead ultimately to prenatal diagnosis, which will be important, and that will be very, very important to understand. And for treatment, what he is mentioning is disease modifying versus symptomatic. That steep disease modifying. Yes.
Sorry, ma'am.
Yes.
Ma'am, I have got Dr. Sumit
He's got it.
slides.
He's got
Can
the
I
slides.
share those?
Very good. Very good. Yeah. Yeah. But this is fine. Yeah. You please share those slides. Meanwhile, as you're sharing, I'm just winding up what the questions were asked.
Yes.
So saying the codon thing and exon skipping, a little bit about that we'll talk about later, and others are symptomatic, what we're giving the steroids and all. So that is one thing which is this is going on and you should understand. But mainstay for us remains steroids and supportive care and multidisciplinary care, or the new trials one, which will be mentioned in the end after Dr. Sumit's presentation is there. We're just saving the time for that time. What is the current status in India for the trials will be mentioned in 2 minutes after Dr. Sumit's presentation. Please, Dr. Sumit, you start. It has been very late. Just
Thank
I
you,
was just
Stephanie ma'am,
not
for
wasting
very nice
time.
talk. I will request Dr. Sumit sir to start now. Dr. Sumit sir.
Yeah.
Okay.
So am I audible right now?
Yes, sir. You are audible,
Yeah.
sir.
Yeah. So next slide. Right, so we will be discussing an approach to a child with progressive muscle weakness, predominantly dystrophies, which has already been discussed, and LGMDs and other kind of muscle dystrophies. Next, so as we've seen the muscle structure, but
Hello, Sumit sir. You are not audible.
next slide, yeah. Yeah, so the muscle structure, as we have seen, has different kinds of proteins, including dystrophin and other supportive proteins. And so the key disorders which we see are the muscle myopathies, which is a static disorder in which the child continues to gain some milestones or progresses very slowly, or muscle dystrophies in which there is slow degeneration. Next slide. Next. Yeah. So as we see that these progressive muscle disorders are genetically determined and they lead to progressive degeneration of muscles, leading to muscle weakness and wasting, which leads to muscle fiber loss and progression of the weakness. Next slide. So the sign symptoms of any progressive muscle weakness includes weakness, including neck flexor, upper arm, proximal arm, the lower limbs, the ocular and the bulbar. The topography is the main thing which determines what kind of illness the patient has. Next slide. So the changes includes muscle fiber loss, including loss of sarcolemmal nuclei, loss of striations, and there is progressive replacement because of with muscle fat leading to weakness, and subsequently the cardiac muscles and respiratory muscles may also be involved, leading to cardiomyopathies and respiratory muscle weakness. Next slide. So the key questions in any neurological processes involve that what is the onset of the process, what is the duration of muscle weakness, and what is the evolution of symptoms. Based on these three processes, you can diagnose and localize what are the different disorders which is there. Progressive muscle weakness, including dystrophies or dystrophinopathies, can have localization to. Next slide. A spinal cord, muscle, peripheral nerve, or NM junction. The prototype disorders of NM junction includes myasthenia, which has a progressive weakness, oculobulbar, and neck weakness, peripheral nerves with including hereditary neuropathies, myopathies, and muscle dystrophies, and myelopathies. So all these disorders can have progressive muscle weakness. So categorized, which are based, can be differentiated on clinical and neuromuscular findings. Next slide. So all the muscle disorders have positive and negative symptoms. Next slide. The characteristic thing is that the dystrophic process have weakness, contractures, and hypertrophies. Exercise intolerance is minimal. Fatigue can be there. Cramps, myalgias, and myoglobinurias are very rare, which are seen predominantly in congenital myopathies and congenital muscle dystrophies. So, dystrophic process is characterized by mainly weakness of different patterns, contractures, and muscle hypertrophy. Next slide. Myalgias are often not there in hereditary muscle dystrophies, and stiffness is also often not there. So when myalgias and stiffness are there, it mainly suggests a toxic endocrinal or mitochondrial myopathies or some variants of the congenital myopathies. Next slide. So stiffness is often also not there. Muscle dystrophic process do not have muscle stiffness, which is often present in congenital myotonic dystrophies and some variants of the periodic paralysis. Next. So myoglobinuria is there in some kind of muscle dystrophies, including limb girdle muscle dystrophies and some kind of dystrophinopathies, and with malignant hyperthermia in Duchenne's muscular dystrophy and central core dystrophies. Rarely, the other variants may also have muscle myoglobinuria. Next. So the next most important is the evolution of the symptoms. Next, which includes the age of onset, having a childhood onset and an adolescent onset. The childhood onset can be there in various kinds of myopathies and some variants of muscle dystrophies like the congenital Becker's, Emery-Dupus, and facioscapular. And the adult are the mainly different kinds of LGMDs, facioscapular, Becker's, and EMDs. So one should know what is the onset of different kind of disorders and its different variants, which leading to the different kind of differential diagnosis. Next. So the course is important. So the rapidity of the progression may lead to different kind of diagnosis, including rapid progression is there in inflammatory myopathies and myasthenias, congenital course or very slowly progressive course, and the typical prototype of progressive disorder, slow progressive weakness, includes the DMDs, LGMDs, and the facioscapular lumbar dystrophy. One often should not forget that there are episodic patterns and as well in which the child deteriorates and in between the child regains his completely neuromuscular course. Next slide. So the family history is essentially important. Next slide, which leads to the patterns of an inheritance, including the X-linked, which is typically there in boys like BMDs and DMDs, and autosomal dominant and autosomal recessive. However, the family history is only helpful if there's a second sibling, the firstborn child affected. The family history may not help in the diagnosis. Maternal transmission is there in mitochondrial myopathies. Next slide. So systemic involvement, next slide, mainly affecting the cardiac involvement, the respiratory involvement, and hepatosplenomegaly, organomegaly can be there. Arrhythmias and CCF switch specifically we look for, as in Duchenne's muscular dystrophies, muscle dystrophies, limb girdles, and mitochondrial myopathies may have arrhythmias, CCF. Some variants of the metabolic muscle disease like acid maltase and carnitine deficiency can also lead to cardiac involvement. Most of these disorders, cardiac involvement, also cause respiratory muscle insufficiency. Next slide. The prototype of disorders having respiratory muscle insufficiency includes the dystrophinopathies, metabolic myopathies, and the mitochondrial myopathies. Next slide. It's very imperative to see the signs of respiratory failure, which includes slow speech, sinus tachycardia, single breath count, leading weakness of the neck flexion, use of accessory muscles of respiration, and bulbar dysfunction. So these are the signs which often suggest that respiratory failure is insufficient. We often think that the child is tired. Parents often think that it's a child is not eating well, not losing weight. So, and often these signs are mistaken. So signs of impending respiratory failure must be seen in all patients with a progressive weakness. Next slide. So next coming is the pattern of weakness. This is the single most important thing in the diagnosis of different kinds of dystrophies. Next slide. So the topography of the weakness. So I'll spend some time on this slide. So 10 cardinal areas of the body are there, and based on the involvement or combination of this, different kinds of muscle disease are involved. So they can be facial weakness, ocular weakness, bulbar weakness, neck flexor weakness, trunk weakness, shoulder weakness, forearm weakness, pelvic girdle weakness. Now the signs of each of them can be very subtle, and if one is not observant, one can easily miss these signs. So the child keeping his eyes open during sleep, his smile not being a good character, poor whistling, poor swallowing, and poor inability to use a straw are the signs which suggest a facial weakness. Ocular weakness is mainly there in NM junction disorders, which may present as double vision, ptosis, and disconjugate eye movements. Bulbar weakness can be present as nasal speech, regurgitation of feed, difficulty in swallowing, and recurrent aspiration pneumonias. Neck weakness is often not directly suggested by the caregivers and has to be observed in there. So the symptoms which are observable and suggested include the trunk weakness, the shoulder girdle weakness in difficulty in lifting the overhead objects, the forearm weakness in form of difficulty in gripping, pelvic girdle weakness in form of difficulty in getting from supine position and standing position, and foot drops. The respiratory weakness can also present as morning headaches, anorexia, and daytime somnolence. Next slide. So based on this pattern, one has to determine what is the pattern of weakness, what is the progression. So we start with the first case, who's a 10-year boy who has history of difficulty in getting up and climbing up stairs for the last 2 years, suggesting that it's a proximal weakness of the lower limb. There's calf hypertrophy, suggesting that there's a dystrophic process. Gower sign is present. CPK is 10,000. DTRs are elicitable. However, there's no neck weakness. So if we saw to the previous presentation given by Dr. Lokesh, all the sign symptoms are pretty similar. However, there is something odd in this presentation, which is that there is no neck weakness. A 10-year boy having progression for the last 2 years and having no neck weakness. What is not known whether other pattern of weakness including the ocular, facial, bulbar weakness is there or not there. So we are dealing with a dystrophic process with a Gower sign. What I have not specified is which Gower sign is positive and which is negative. So we'll go to the next slide. Can someone play the video, please?
And probably the video is not
You
playing.
can you can just
Can we skip it?
right. So
It's not embedded in my slides.
you can
So
you can just you can click the play button at the bottom of the video.
it's not coming in my
Pratik,
slides.
Pratik, niche. Can you describe, please, Dr. Sab, can you decide?
Yeah,
Dr. Sumit,
yes,
can you
sir.
describe
Yes,
उसमें क्या था?
yeah.
हाँ, बता दो. हाँ,
Right,
describe.
ma'am.
Yeah.
The Dr. Lokesh has beautifully described the cover sign in the previous video. What we see in this video is that a child is able to get up pretty quickly. He does not have the typical abduction phase of the cover sign. And in the next slide, we see that there is no affection of the iliopsoas, there is no affection of the neck flexor. So suggesting that predominantly the lower limbs are affected, the iliopsoas are spared, the neck flexors are spared, the truncal muscles are spared. Next slide. So how we must be clear-cut able to differentiate on a clinical basis on dystropathies and LGMDs based on the pattern of weakness. In the previous presentation, we saw that pectorals were predominantly affected, triceps were affected, the hip extension was affected, the abductors were affected, and the knee extension was affected. However, in this child, what we see that the topography is different. The hamstrings are more affected, the iliopsoas are less affected, the adductors are less affected. So, based on the pattern of Gowers itself, we know that the pattern of disease is not like a dystrophy or a typical DMD. So this was the first point we have to think based on simple observation that in this case Gower 2 is positive and Gower 1 is negative. So we are not dealing with a dystropathic process in this case. Next slide. So based on this, now pattern of weakness, one must be able to define what kind of dystrophic process is this. So the six most common pattern includes the proximal weakness. One is a combination of a distal weakness. Next is a combination of the proximal arm plus the lower limbs. Next is affecting the proximal limbs and the uh, lower limbs distal weakness, and some variants also having ocular and bulbar involvement. So if we see our history, our case sheet, we must clearly draw a diagram something like this, suggesting what are the patterns of involvement. So if we draw these patterns clearly, the diagnosis is self-evident. So in this child, what we saw that he had a proximal limb girdle type of weakness. He didn't have ocular weakness. He didn't have bulbar weakness. He didn't have ophthalmoplegia. There was no neck flexor weaknesses, and there was no evidence of distal weaknesses. So we are dealing with the prototype of the proximal limb girdle weakness. Next slide. So in which there are a lot of differential diagnosis, including the DMDs and different kinds of LGMDs. Most kind of hereditary and acquired myopathies have this pattern involving the hip extensors, the ankle flexors as well as ankle extensors, and also the truncal involvement. So however, this muscle disorder in the index case didn't had a lot of truncal involvement, didn't had upper limb involvement, didn't had neck flexor involvement. So the differential diagnosis in this case is pretty wide. So next slide. Right. So we proceeded with a specific testing of the genetic mutation, which was suggestive that it's a calpainopathy. Calpainopathy is one of the most common LGMD type, with almost ranging from 1/3 to 40% of the cases. With different cases of calpainopathy can also have hypercreatine kinase elevation, and some can also have eosinophilic myelitis. What happens in this disorder is that there's a specific calcium activated neutral proteinase which gets activated and which impairs muscle regeneration and sarcomere modeling, leading to muscle loss. Next slide. So the onset of presentation varies. Most of the cases have childhood and adolescent onset, with almost 1/3, 2/3 having onset before less than 30 years of age. The children are having thin habitus. They may have toe walking, ankle contractures. As we see in the previous video, that the proximal lower limb contractures are also there. The lower limbs are much more weaker than the shoulder girdle from the outset, and hip extensor, knee flexors, and hip adductors are the predominantly affected muscles. The truncals and the upper limb muscles, the shoulder girdles, are relatively spared. Next slide. Other signs of other limb girdle muscle dystrophies include abdomen laxity, scapular winging, sometimes elbow contractures and hip contractures develop late in the progress. They progress slowly, and ambulation is often lost after 1 to 2 decades of their disease. And the later the onset, later the course is the milder. So children having onset less than 10 years of age have a bad course. The children having adults having onset more than 15 to 20 years of age have a relatively milder course with a lifespan of 40 to 50 years. Cardiac and respiratory dysfunction often is there during the later part of the illness. Next slide. So creatine kinase is one of the important steps in the investigations of any muscle weakness, which can be elevated as high as 2 times to 100 times of the upper normal limit. Muscle biopsy reveals non-specific features. Lobulated fibers can be there in half of the cases, and in such a case, Western blot analysis is very helpful in the diagnosis of calpainopathy, which has reductions in the calpain bands in almost 80% of the cases. So when a child presents with a prototype of weakness of the lower limb affected, truncal sparing, neck sparing, elevated creatine kinase, one has to think of diagnosis of calpainopathy, which is one of the most common limb girdle dystrophies seen in childhood and adolescent population. Next slide. So again, it's a very heterogeneous group. Age of presentation varies, and all kinds of presentation from childhood to late adolescent and adulthood is seen. Next slide. So again, they are autosomal dominant and recessive. The number LGMD1 refers to the letter designated in the order of discovery, and there is slowly progressive weakness. What one must know is that one genotype can present with different phenotypes, and one phenotype can result from single genotype. Next slide. So again, the most common adolescent adult variants with limb girdle weakness includes the dystrophinopathies, calpainopathies, and Foucaultinopathies. The most common.
Sumit sir, please unmute yourself. Sumit sir. Sumit sir, unmute yourself.
Yeah.
Okay.
Right. So the most common adult onset limb girdle includes dystrophinopathies, calpainopathies, and some variants of the distal myopathies, including dysferrinopathies. Next slide. So as we see that the LGMD type 1, which is the autosomal dominant, has a predominantly presentation in childhood and adolescent. They have slow presentation. The most important notable part is that the creatine kinase is elevated to less than 10 times in most of the cases, as compared to LGMD type 2. Next slide. In which the creatine kinase elevations is as high as 10 times to 100 times. They have much earlier presentations compared to the LGMD type 1. The progression is much rapid, as we discussed. The earlier the age of onset, the more rapid is the presentation. And this type mainly includes the calpainopathies and different kinds of dysferrinopathies and sarcoglycanopathies. Next slide. So there are certain LGMD disorders which have foot drops. They may have asymmetry in weakness, which is not the prototype features of muscle dystrophies. They may have limb contractures, including seen in lamin myopathies, EMDs, and BAC3 myopathies. And sometimes they may have muscle cramps as well. So these are the atypical features in which are not commonly seen in muscle dystrophies. Next slide. So some of variants can have scapular winging, calf hypertrophy, cardiac conduction abnormalities, cardiomyopathies, and the muscle biopsy and EMG may show something called as rippling muscle phenomenon and percussion-induced muscle contractions in one of the variants. Next slide. So rarely, if the genetic testing is negative, one may have to proceed to muscle biopsy to differentiate certain kinds of muscle dystrophies to see pathologic phenotypes like rimmed vacuoles, reducing bodies, cytoplasmic bodies, and derangement of myofibrils. So these disorders may have a negative genetic testing, and sometimes the biopsy can help in clinicopathological and genetic correlation. Next slide. So with this, we come to the next phenotype of the case. Next slide. We have a 10-year-old boy who has difficulty in raising the arms and climbing from stairs for the last 2 years. So there's both upper limb as well as lower limb involvement. Proximal involvement is there. There is face affection with thinning of the face and upper arms. However, we don't see any fasciculations. The reflexes are elicitable. Now we the creatine kinase is normal. Now, the role of a clinician is much bad, much difficult when there's a proximal weakness, there is no hypertrophy, and creatine kinase is normal. So, in this case, how do we proceed? Next slide. There's an important sign to see for the abdominal muscle weakness, which is called as the Beaver sign, in which what we see is that the upward cephalad movement of the umbilicus upon truncal flexion while the patient is in supine position. This is a very simple clinical sign to see for abdominal muscle weakness, which is there in very few muscle dystrophies, which was present in this case. Next slide. And the topography of the muscle weakness is important. We see that there is scapular winging. We see that there's something called as the multiple hills. So 1, 2, 3, and 4, which is called as the polyhillsile. There is shoulder blade atrophy. There is neck atrophy. It's a thin face. Next slide. And another close-up look suggests that there is a upper limb pectoral atrophy. There is a biceps, triceps atrophy. There's facial weakness. and scapular winging. This is something called as a polyhill sign, in which we see that there are four hills. One, the first sign related to the scapular thing. The second is the acromioclavicular joint. Third is related to inferior deltoid muscle prominence, and the fourth is related to the forearm. So this is the typical polyhill sign, the scapular winging, and the facial muscle weakness. Often this sign is also called as the Popeye sign, in which the cartoon character bears a similar resemblance, in which the elbows are much thicker and the arms are much thinner. Next slide. So again, a similar lower limb photograph, in which there is lower limb thinning, there's abdominal muscle weakness, there is scapular winging, and also the facial muscle weakness is also seen. Next slide. So this pattern of weakness, in which there is a predominantly proximal arm weakness, to some extent distal leg, which is called as typical scapuloperoneal weakness, and face, neck, bulbar weakness can also be there. So the prototype of the diagnosis is a facioscapular humeral dystrophy. Often this phenotype can also be there in some variants of LGMDs and scapuloperoneal dystrophies. Next slide. So the diagnosis based on clinical phenotype, abdomen muscle weakness, Beaver sign, the upper limb weakness was a facioscapular dystrophy. It's autosomal dominant, the presentation age being childhood to early adolescent age, which presents with proximal muscle weakness and atrophy involving face, scapular, proximal arm, and peroneal muscles. There's facial weakness with winging of scapula and severely affected upper limbs and shoulder girdles, muscle weakness, and foot drop is there late in the disease. Lifespan is typically not affected because the respiratory muscles are often spared. Cardiomyopathies can be there in the later part of the disease. Next slide. So we come to the next prototype of the case presentation, including next slide. So this child is a 15-year-old boy who is symptomatic for the last 6 months, who has similar symptoms of proximal weakness of the lower limbs, upper limbs, difficulty raising the neck, voice change, and difficulty in swallowing. However, the most alarming sign is that he cannot get up unsupported. There is no diurnal variations, there is no fasciculations, no contractions, and no hypertrophy. The creatine kinase is 4 times the upper limit, 4 times the upper normal limit of normal. So now what is different in this case is that the child has a predominant neck flexor weakness, and which can be there in along with limb girdle in different kinds of DMDs and inflammatory myopathies and facioscapular dystrophy, as we saw in the previous slide. Next slide. The most important thing is that the onset to peak of the symptoms was 6 months. So if you see these 4 diagnoses, DMDs do not have such severe weakness in 4 months. Facioscapular dystrophy has a very slow progression, including years. So by exclusion, we see that the most likely diagnosis would be inflammatory myopathies or some variants of the metabolic myopathies. We saw that there was no myotonia, the course was rapidly progressive, and we didn't much probe in the history of hypothyroidism in the history. So the most important is limb girdle pattern of weakness with neck flexor weakness with a very rapid course suggests the possible diagnosis of inflammatory myopathies. Next slide. Which includes a prototype of dermatomyositis and polymyositis. The diagnosis is very easy if skin abnormalities are present and rash is present. However, the diagnosis of polymyositis is often delayed because of lack of skin manifestations, and other autoimmune disorders like SLE and Sjogren's can also have a similar presentation of inflammatory muscle diseases. Next slide. So basically, dermatomyositis is an autoimmune disease affecting skin and muscles. The symptoms are pretty rapid over weeks and months. There's often a peculiar rash on the face and the neck. There is facial edema. There's a proximal muscle weakness, neck flexor weaknesses, swallowing difficulties, cardiac difficulties, and sometimes in adults, a paraneoplastic etiology also has to be considered. Next slide. This is the typical facial rash, the perioral rash, facial edema which is seen, and the rash involving the neck flexors, and rash also involving the knuckles of the hands and the face, Gotron's papules, they are the typically called. Next slide. So the management includes a lab evaluation including creatine kinase. However, creatine kinase can have a very wide fluctuation in clear-cut cases of dermatomyositis, ranging from normal to as high as 10 to 15 times. Muscles EMG has a diagnostic value which shows the patterns of myopathic MUOPs with fibrillation potentials. So this is the easiest diagnosis. Once you put in a needle, you will find myopathic findings with some denervation potentials. So this finding is virtually diagnostic. Muscle biopsy is often now not done these days because it's an invasive procedure and the risk of sedation and precipitation of the respiratory weaknesses, however, which may show muscle inflammation and endomyosial inflammation. And therapy includes immunomodulation and long-term immunosuppression with corticosteroids. Next slide. So the other rare patterns include the distal arm and the proximal weakness, which is there in seen in inclusion body myositis, which is uncommon in childhood and adolescent. Next slide. The other rare patterns isolated includes bulbar weakness with only tongue and pharyngeal weakness without the limb girdle pattern seen in myasthenia and rarely in Lambert-Eaton, which is seen in older age with paraneoplastic etiologies. Next slide. And other patterns of weaknesses including episodic weaknesses, myoglobinuria, rhabdomyolysis, which may or may not be related to exercise. So those which are related to exercise includes the glycogenolysis and the lipid disorders. And there are list of congenital myopathies which may have episodic presentation, the periodic paralysis, and sometimes precipitation of malignant hyperthermia as well. Next slide. So again, there can be distal myopathies as well, which includes early onset, adult onset distal myopathies type 1 to 3, and some variants of the congenital myopathies, inclusion body myositis, and myofibrillar myopathy. Next slide. Sometimes ptosis and ophthalmoplegia can also be there, which is cardinal of the feature of myasthenia, mitochondrial disease, as well as some variants of the congenital myopathy. Next slide. And rarely we may have episodic weakness, delayed weakness related after exercise, or sometimes which may not be related to exercise, and disorders involving muscle stiffness like myotonic dystrophy and paramyotonia, in which there is stiff muscle and there is inability to relax. Next slide. So we come to the last case. Next slide. In which now this is a adult who is 28-year-old female with diffuse weakness, muscle thinning. However, the onset was at 16 months of old. When she started running, there was difficulty in running and difficulty in getting up from the floor, which suggested a lower proximal weakness of the lower limb. And she had a rapid progressive course in which she was wheelchair bound in the next 3-4 years. The creatine kinase were only 2 times. At the age of 21 years, she had generalized atrophy of the appendicular muscles and the lung functions were also impaired. What is important is that to know is the progression of the weakness with lower limb predominant weakness and a wheelchair bound child who's alive till 30 years of age. Next slide. Now, what we see in this slide is that a female who is sitting, who is bed bound, who has contractures of the hip and knee and elbow. There is thinning of the proximal upper limb, the facial, there is no facial weakness, there is no ocular weakness, then there is no bulbar weakness. And there were contractures as described. Next slide. So, and the genetic sequencing identified the mutation in lamin ACG consistent with the diagnosis of LGMD type 1B. Next slide. So, to summarize, the patient with any muscle dystrophy, we must determine the pattern of weakness, which is limb girdle, humeropectoral, or distal. Next. And determine the likely inheritance pattern if there is a similar family history as X-linked, autosomal dominant, autosomal recessive. Next. And we must identify the typical features, carp hypertrophy, if associated, systemic complications like cardiac or respiratory involvement is there, and specific EMG features like myotonic or pseudomyotonic disorder discharges, which are specific to the specific etiologies. Next slide. And then ordered a targeted genetic testing. Targeted genetic testing meaning that a specific mutation for specific FSHD or LGMD. Next slide. And if we have a diagnosis, then there's nothing further need to be done. If there is no specific diagnosis after a specific muscle testing, then one may proceed with the muscle biopsy, targeted genetic testing, or whole genome and exome-wide screening analysis, which is the next generation sequencing. Next slide. So again, another approach is that a patient with selective pure muscle weakness with preserved sensory examination must be evaluated for muscle dystrophies, myopathies, and myotonias. So these 4 disorders, besides the muscle dystrophies, are very easily excluded based on history alone, including congenital myopathies, channelopathies, metabolic myopathies, and mitochondrial myopathies. The muscle dystrophies. Next slide. Like Duchenne's muscular dystrophy, myotonic dystrophy, and facioscapular dystrophy can be easily diagnosed by the pattern of weakness and the course and evolution of the symptoms. Other dystrophies like the limb girdle and the distal muscular dystrophies. Next slide. Next slide. Again, so this is the most important pattern, that identifying the pattern of the illness, the limb girdle, humeropectoral, and the distal weakness. Next slide. And the pattern of inheritance. Next slide. Again, so the key points is that the initial key to the diagnosis of myopathies and muscle dystrophies is the recognition of the clinical pattern. The sequential 6 questions which the clinician should ask is in arriving the pattern that fits in the patient. And after arriving at the pattern, the clinician must determine the most appropriate diagnostic test for the management.
Thank you so much, Dr. Sunu. Despite of the technical glitches, sorry for the delay for all the technical glitches, which is nobody's fault, was technical. Can we take up, Pratik, can we take up some questions for next 5 minutes?
Yes, ma'am, definitely, ma'am.
Pratik?
Yes, ma'am.
Okay. So basically, while finishing what when the part, this something it's muted. It's get muted automatically. So can you please see from the brow bliss? Can you see that it should not get muted in between, so that it doesn't waste more time? So what
Yeah.
somebody had asked in the end, what we were just summarizing that they were asking about the newer therapies which are there and the exon skipping one, right? The carrier one was finished and the progression was done. Duration of steroids was mentioned and clinical stage. Dr. Lokesh, do you want to mention the exon skipping and all? The skin biopsy substitute, which I've already told. Skin. You want to explain, or you want me to tell very briefly? If you want, you can tell. Dr.
Yes,
Lokesh.
ma'am. Exon. So
If you want to tell.
Yes, ma'am. Yes, ma'am. So exon skipping is whatever mutation is there, we want to skip that part and we want to continue to the reading frame, and to at least some form of protein is made. What is happening because of a mutation in the pre-mRNA, there is early termination of the reading sequence, and there is a formation of stop codon. So what you are going to do, that mutated codon, you want to make a antisense oligonucleotide which binds to that mutated part, and after binding, when it binds to that, what happens is that part skips when pre-mRNA is translating into mRNA. That parts get skipped so that reading frame continues, reading frame preserves, and a dystrophin can be formed. So this is the basis of exon therapy, and I don't think so at present we are doing any sort of exon skipping therapy in India right now. I think ma'am will enlighten us regarding this. Ma'am, are we doing
Yeah.
like?
Yeah. Actually, one second. Now, what we had between our pediatric with the patient was being followed up by a child neurology clinic and genetics, and there was one patient who did, apply for funding for Exondys about 2.5 years back, and by the time the drug was permitted to be purchased by the government, the child had become, wheelchair bound. So, but in January 2020, he was started on this Exondys, but he has had after 6 months, 6 to 7 months also, there's not much improvement because he was not in much improvement in muscle function. Regarding, this Betoloris, that is 51 Exondys, and we had the Betoloris 53, which was going to come up in India, and there were 7 sites in India, including PGI, AIMS, CMC Vellore, and many more, who had been selected, but then suddenly after lockdown, they have decided not to come to India. So that exon skipping part is not there. So basically, wherever the exon there is a deletion there, as what he mentioned, the antisense oligonucleotide is going to bypass that deletion part, so that the whole thing, the protein is formed. That is crudely speaking. And the Atalurin one, which are the trial, we're continuing. We are there. AIMS is one of the sites in India. We have 11 patients recruited, but the recruitment was finished in September 2020, and the follow-up will continue. In that, there is a premature stop codon. Then the protein formation stops. So what this Atalurin is going to, it interacts with the ribosomes, and because of the transfer RNA produces that it reads through the thing. So that is how it's being trying to be done. Something just new which is also there is a eutropin upregulation. That is a homologue. Eutropin is a homologue of dystrophin, and that gets upregulated as such in the DMD patients. So by using drugs like ezetimibe and all, that is being tried, and other studies are going on corticosteroid replacement therapies like vamorolone are going to be used as a corticosteroid substitutes. And one last thing, something which got approved in July 2020. And why I'm mentioning to you, because we have done that something in AIMS as a small part, which has not led to that, but we have also done from skin biopsy in AIMS, we have generated induced pluripotent stem cells, which have gone into form the muscle cells. This was done as a part of some PhD thesis of Pooja and has been published in PLOS ONE. But actually, a lot of study has been going on in induced pluripotent stem cells. And in that, you can have from the skin biopsy or even from the blood, you can develop these stem cells and produce the specific ones. So there is one particular stem cell, which is BTA10, which has been, given a FDA fast approval, and they are doing the trials and the approval was given in July 2020. So many things are on, but these are so exorbitant, as it's been mentioned to you, 5.3 crores and 2 crores annually, which is beyond anybody's thing until unless for a compassionate ground, but no compassionate ground is going on for DMD, but a lot of compassionate ground is going on in SMA, which we have some with gene therapy also, and Spinraza, Nusinersen, and also Resdiplam, but nothing like that is going on for DMD. We should understand that we have to see the child holistically and give them the whole thing. They have to be given patient information booklets, have to be closely followed, and see holistically as follow-up, as very nicely mentioned by Dr. Lokesh. And still, the mainstay remains multidisciplinary support on the background of steroid. That is what it is there. Either you're giving your prednisolone or you're giving deflazacort. Thank you so much. I think we just move on to the LGMD questions. And LGMD, we have to understand, it has to, Dr. Sumit is very nicely portrayed on that. The NG, basically, all of these are going to present with progressive muscle weakness with a normal sensory examination. And we have to understand. And basically, what happens is the most important recognition, as he said, is of the phenotypes. whether it is a DMD phenotype, whether it's a scapuloperoneal, whether it's LGMD. So basically, which muscle groups are involved is important. And as I mentioned to you earlier, why we are different muscles are hypertrophied and which are effective has been postulated because of differential expression of the proteins which are there. There was a question how sarcoglycanopathy is different from Dr. Sumit. Can you please answer that? Sarcoglycanopathy differentiated from.
Yes, ma'am. So sarcoglycanopathies also have a presentation of the predominantly lower limb weakness with truncal weakness. However, we see that the upper limbs are predominantly spared, the neck flexors are spared, the course is relatively slower compared to the DMDs. Their life longevity goes up till 20 to 30 and sometimes 30, 35 as well. The CKs are also elevated just like DMDs more than 10 to 50 times, so that may not help. So again, the pattern of Gowers, the clinical phenotype, the pattern recognition helps clinically. That is the most important part.
Okay. So basically, they are different. The other one is asking about whether you have any CNS findings which are there. Yes, you may have CNS findings with, FKRP related one. There's some specific LGMDs. You may have some CNS findings and you may have some intellectual disability in these children. That is there, but not usually. And congenital myotonic dystrophy with congenital myopathies. I think we had that myopathies thing yesterday, and congenital myotonic dystrophy. Dr. Amit, would you like to answer? Congenital myotonic dystrophies. Myotonic
Yes,
dystrophies.
yeah.
The question is
So
congenital myotonic dystrophy from congenital myopathy. Congenital myopathies were discussed yesterday in detail. So what exactly is congenital myotonic dystrophy? Can you just mention so that they have some pointers how it will be different from myopathy?
Right. Congenital myopathies often present late. They do not present at birth or usually in the first year of life. They may have initial delay in developmental milestones. Congenital myotonic dystrophy have presentation right on day one of life. The facial phenotype is typical with the pattern of temporal hollowing. The respiratory weakness is often there in the first month of life. That is the clinical pointers that may suggest that the severe onset, severe respiratory muscle weakness and proximal weakness and facial weakness suggest that the possible diagnosis of congenital myotonic dystrophy. The examination of the mother, that's the most important part. So in any newborn with the suspected weakness of face and respiratory muscles, the mother must be examined for myotonia, delayed relaxation of muscle, which clear-cut points out towards the diagnosis. So the congenital myotonic dystrophy is
So,
very
yeah.
yeah.
So basically, as that's a clinic, it's a phenotype, which you can see, and you may have historically polyhydramnios in the pregnancy with the basically hatchet-like shape of set with the vertical forehead, and you have a specifically, tented upper lip, temporal hollowing, and open mouth due to jaw muscle weakness, and they generally present with neonatal respiratory distress syndrome and hypotonia with weak suck. So basically, that's how. And as Dr. Sumit has mentioned, mothers, we will get percussion myotonia or the grip you can test for the mothers. And just to clarify one thing about the sarcoglycanopathy, something important for you to know as PGs also, when you are asked the differences, the scapular weakening, yes, and your, adductors are involved more in the hip. So Dr. Satish Khadilkar, you should know that is why, because Dr. Satish Khadilkar from Mumbai, he has described a hip abduction sign, which they say that, because the adductors are involved more, so and as we mentioned that modified Goyer sign is there. So that was more going towards of sarcoglycanopathies in which we are seeing it beyond 5 years of age. So that is important. We should know the signs which are described by our fraternity. Right now, there are multiple regarding the therapeutic things. Multiple advances are going on. We should just understand on the lines of same things. Having a vamorolone modified steroids in the induced pluripotent stem cell gene therapy, exon skipping. All of these, are being tried in LGMDs also. So things are on, and but still way beyond from actual practice. I think we will wind up right now, and Thanks. Sorry for the technical glitches, but I think it was a very constructive thing, and we should understand and understand dystrophinopathies and LGMD as different spectrums, and mostly based on the clinical phenotype. And then obviously diagnosis will be based on the muscle biopsy and genetic testing in most of the situations. And new therapies also coming up, we have to keep a multidisciplinary approach to the patients. That has to be kept in mind. And I hand it over back to Pratik and Inder. Thank you so much.
Thank you, Professor Sefali Gulati ma'am, and Dr. Sumit sir, and Dr. Lokesh sir. It was a very nice presentation on both sides. I sincerely apologize for the technical glitches, but Sefali ma'am nicely explained all the nitty-gritties of Duchenne muscular dystrophy and limb-girdle muscular dystrophy. And I want to express my gratitude on behalf of Child Neurology Division to especially to Professor Sefali Gulati ma'am, who spared a lot of time in spite of her busy schedule, and both the speakers also. Thank you everybody. Thank you all the attendees. Tomorrow we'll take the third session on spinal muscular atrophy and neuronopathies. We will be sharing the links shortly. And thank you everybody. Good night. And again, thanks to everybody for attending and with patience. Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Thanks. Bye. Bye. Thanks. Thank you. Thank you.